For everyone with an interest in NASH, or more broadly, fatty liver disease, SURSUP, Season 3, Episode 54 of Surfing the NASH Tsunami, our real-time coverage of a couple of very eventful days at the Liver Meeting 2022 starts now.
Today on Surfing the NASH Tsunami.
I think the one word I would take away is excitement.
That's interesting. I was going to go for optimism. I think we're kind of in the same place on that.
What would a change of name mean when we're talking on the edge of drug development and we are on the edge of really making some big leaps in terms of awareness and communications? I have to question the timing of this and if this is the most important thing for the field to be dealing with.
The dynamics of what happens when you have reset the disease to a point where there is far less liver damage and activity is still an unknown to me, but an important thing to investigate.
We've really got to think about how we're actually going to use these drugs now, how we're going to select patients for treatment. It's not a one-size-fits-all approach, but the reality is trying to come up with bespoke testing strategies in different populations is only going to make things more difficult rather than easier, and I would like to see if we can try and find a unified approach that identifies as many people as possible so that they can be treated appropriately.
The FAST score tends to stand out over and over again. Whether you look at screening strategy, you look at isolating for at-risk NASH, the so-called NAS4 more with F2 to greater fibrosis, and it's something that is generally readily available.
The drug development arena is a critical step closer with FDA decisions based on the available OCA data with more safety we saw and the drugs that Stephen presented. We're moving full speed ahead with drug development in that arena.
We have some far-reaching conversations on this podcast, but I would say this one is going all the way from hither to yon and back again. Lots of focus, lots of perspectives.
This week, roughly 7,000 hepatologists and hepatology stakeholders have gathered in Washington, D.C. for the Liver Meeting 2022, the first in-person AASLD with on-site attendees in 3 years. Please join hepatology researchers and key opinion leaders Professor Jörn Schattenberg and Dr. Stephen Harrison, pricing and forecasting guru Roger Green, and today's guests, hepatology researchers and key opinion leaders Professors Sven Francque and Ian Rowe, and Global Liver Institute Vice President of Health Programs, Jeff McIntyre, as they review some of the highlights and key issues from Monday at AASLD on this special episode of Surfing the NASH Tsunami.
This episode of Surfing the NASH Tsunami is sponsored by Inventiva, a leading French biotech company developing novel and differentiated oral small molecule therapies for patients with NASH and other diseases with significant unmet medical needs. Listen for an interview with Inventiva Chief Medical Officer Michael Cormin, Stephen Harrison, and Roger Green at the end of today's AASLD review.
So for those of you who heard yesterday's podcast and the two of our guests were unable to show up for whatever reasons, we have a full house today. Well, everybody who said they were going to be here is here. Stephen Harrison here is having the first two late breakers in yesterday's afternoon session, late breaker session. Stephen, how are you doing today?
I'm doing wonderful. It's been a great meeting. Thank you for having me.
Yeah, well, thank you for joining. And then I guess the rest of our KOL contingent is all from the other side of the pond. Sven Francque. Sven, how are you this morning?
I'm fine. Yeah, it's really a pleasure having been here. Unfortunately, I have to go back today, but it was a great meeting so far, so it was really a pleasure to be here.
Good. And then I'm going around my screen and counterclockwise. Jörn is back this morning, as he is pretty much every time we do this. Jörn, how are you today?
Good morning, Roger. I'm fine, thank you. I stopped waking up in the middle of the night, and now I have to go back too, so it'll be the other way around. A little bit painful, but I hope I settle in quickly.
You're a pro. You'll get this done. And then staying counterclockwise, we have Ian Rowe, who claims to be in the smallest hotel room of any of us. Good morning, Ian.
Morning, Roger. It's not a claim, it's a fact. It definitely is the smallest. But no, I've really enjoyed the meeting too. It's been a pleasure to be over here for the first AASLD in person in a while.
Yeah, okay. Well, so I know you're a data guy, so I assume your claims are all facts. And then to your left on my screen, we have Jeff McIntyre, who is actually staying in a hotel, although he lives in D.C. Jeff, good morning.
Yeah, good morning, gentlemen. Good to see everybody.
Okay, so with that, we'll do Groundbreaker really simply. The one image you are going to take away from this meeting that you want to share with those who didn't get to attend. Brave one, go first.
All right, I'll go. I think the one word I would take away is excitement.
That's interesting. I was going to go for optimism. I think we're kind of in the same place on that. I think that pervaded the meeting. I totally agree. Next.
Yeah, well, I'll go next. I think the thing that I've taken away is that people are talking about treatment, and it's kind of the optimism thing, but it seemed to me that there were 2 or maybe 3 different conversations happening in parallel. There was a lot of, I think, Stephen's right, excitement about the presentations yesterday and the prospects of drugs coming soon. But I think outside some of those sessions, people were talking about the impact that the obesity drugs are already beginning to have in the way that patients are being managed in the clinics today, not necessarily in hepatology clinics, but in diabetes and endocrinology clinics and elsewhere.
That's fascinating. Interesting way to think about it. Sven, go next.
Yeah, I can only share the feelings of excitement and progress that has been made in the treatment. Another highlight for me was also the progress that is made in the process of the nomenclature. We're not there yet, but that's also a whole debate going on. And clearly also there is substantial progress made and enthusiasm to go ahead with that process.
I'm hoping we'll get to that a little bit on today's conversation, although it wasn't part of yesterday, it was part of Sunday, but I think there are a bunch of reasons to get there. And so, Jörn, one impression?
Yeah, it's a wind of change. The picture I want to share is I walked through the industry hall, and in the middle of it, there's a bunch of small booths, and they actually include companies that do medical education around NAFLD, and I haven't seen that. So I think they're joining our meetings to start learning what we have been looking at for so long and trying to export that to the broader community. And I've met with one of them, and I'm really excited and looking forward to get these programs to educate peers that are not as intimately as involved as we are, informed of what's been going on.
That's fantastic. And then, Jeff, your impression?
I'm going to go with the impression from nomenclature as well, as Sven mentioned, but mine's going to be very different, which is that was one of whimsy, which is not a word you hear thrown around scientific conferences a whole lot. I was in the back of the room, as I often am, for these conversations, and was kind of, while I was watching the presentation and the screen, I was also kind of monitoring on LinkedIn and what remains of Twitter, what was going on with the comments, who was making anything, and across the board, and this happened coming past me as well, the most tweeted thing that went out was the pigeon that walked down the aisles of the nomenclature and then flew around a little bit. And it was this moment after the pandemic of being able to make eye contact with strangers and share a quick laugh over something, and just kind of realizing how much I've missed that. And it was in the midst of all the seriousness, getting to kind of share a laugh and a little bit of whimsy over the pigeon. And I would direct people to Roger's feed on LinkedIn for one of those photos.
I posted mine before I saw any of the others.
It was freestanding on Twitter for quite a while when searched for liver or AASLD tweets as well.
Well, actually, my disappointment, Jeff, is that there were all these pictures of the pigeon in different parts of the room, but for a while, the pigeon was flying at the top above the speakers. Right. And I was trying to catch a still so I could talk about the lofty rhetoric and how the pigeon was responding, but I couldn't get the picture.
There's so many great metaphors and analogies of the moving target and not be able to pin it down and unexpectedness, etc. It was almost akin to the little bird that landed on Bernie Sanders' podium when he was running for president in the last cycle or two. It was a lovely moment.
I would have liked it to be a white pigeon.
Well, hey, Sven, go all the way. Let's get a dove at that point, right? So with that, why don't we get started? I think format's pretty simple. I'm going to go in alphabetical order, except I'm taking myself out of it. Ask Sven to go first and just talk about one presentation from yesterday that you think was important and want to comment on. And then we're going to go, as I say, in alphabetical order to Stephen and to Jeff and to Ian and to Jörn and then back to me. And here we go. So Sven, why don't you lead us off?
Yeah, of course. There were many very interesting presentations yesterday, and I know some of the others are going to cover other presentations. I want to go for one of the very last presentations, which was by Laurent Castera, who presented a very interesting study on the performance and a head-to-head comparison of different non-invasive tests, the FASTTM, MAST, the MEFIB, FIB-4, NAFLD fibrosis score on patients with type 2 diabetes. What was very particular to this study and very interesting was the way they selected the patients. So they reached out to their diabetology clinics, but the inclusion was not based already on those non-invasive. It was really just based on the liver enzymes. So on ALT with low thresholds, so 24 female patients and 34 male patients. And that was the threshold, and of course the exclusion of other liver diseases to propose a liver biopsy to these patients. And so they ended up in that collaborative effort with 330 patients, if my memory is is okay with a liver biopsy, and within a time frame of less than a week, also all the other investigations to look for diagnostic accuracy. Of course, they looked into different conditions to diagnose with the non-invasive approaches, but the most important one where Laurent reported the data on was on fibrotic NASH, so NAFLD activity score of 4, and then F2, F3 or F4. Biopsies were read centrally by Pierre Pedosa, so it's quite a stringent reassessment of all the biopsies by one central reader at one single time point. So that gives quite a uniform reading of the liver biopsy. And then in terms of the results of the performance was that the best results were with the FAST and the MAST, but still there you had an OROC of 0.82 for the FAST and 0.79 for the MAST. And then the other ones performed clearly. Those two were outperforming the other ones. And so that's really interesting results, because also it's not just about the OROC, it was also about those that were correctly classified, not correctly classified, and also the gray zone in between, which was narrowed down to about 10%, 11% with the MAST, but was about 40% with the FAST scoring system. So there was some discussion in the room, very interesting discussion on how this compares to what we already have as data on the accuracy of those non-invasive tests. And of course, you can discuss always that the reference method here is still the liver biopsy. But the most important thing here to me was the selection of the patients. They were not pre-selected on already an elevated liver stiffness or a FIB-4 or whatsoever. It was a low threshold to go for a liver biopsy. It gives you a less biased cohort, I would say. It's of course not unbiased. There is always a selection criterion, so there is always selection bias. And another important conclusion from this study was that the condition itself, so the fibrotic NASH, was present in just a little bit less than 50% of the population, which is a huge and cumbersome number. We need to have more details on that, and that was also the discussion in the room, how to understand also the discrepancies between the liver histology and the imaging-based, mainly imaging-based non-invasive tests, and to better understand why you can have those discrepancies, and also why it's, in terms of accuracy, a little bit lower than what is mostly reported in the literature. So they still have to dig into the data to answer all these questions, but very interesting data. And as I said, the fact that nearly 50%, it was a little bit less than 50%, but it was approximately 50% had fibrotic NASH, was also to me a very important result of the study. In people with sometimes very low ALT levels, just above those low thresholds of 20 and 30.
20 on women, 30 on men, if I remember correctly.
Yeah.
Who else saw the presentation or had reactions? I was there, but others?
I didn't see it, but just hearing Sven's comment, I can just add a little color to that from a presentation that we gave on Sagimet, looking at AI digital pathology and linking that to NITs. That's the first time that's been done. You know, all these NITs have been compared to other NITs in liver biopsy, but never to more of a continuous scale, an AI continuous scale. So when we looked at all these patients we screened in for the Sagimet trial, it was over 1,200, I believe, patients that were screened in. And then we compared the screening data to the screening liver biopsy. And we took that and looked at the total percent collagen content by histoindex. What stood out to me was the correlation between percent collagen and the FAST score. Correlation was in the 0.45 range, if I remember correctly. And this was highly significant. The other thing that stood out was AST value alone. And as Sven mentioned, you know, MAST and FAST both have AST in them. And I just think that the FAST score tends to stand out over and over again. Whether you look at screening strategy, you look at isolating for at-risk NASH, the so-called NAS of 4 more with F2 to greater fibrosis. And it's something that is generally readily available. Not everybody has a FibroScan, but there are more FibroScans than there are MRI machines. So I just find that helpful to see it stand up over and over again, whether it's a diabetic clinic, it's a screening population for a clinical trial or whatnot. So, you know, just reinforcing what we're seeing with that score.
So let's spend a couple of minutes on this broad issue. I mean, Stephen, I think, broadened it appropriately to the question of what we've learned about those tests this week. And then I want to make sure we have enough time to talk about drugs and nomenclature. I have some thoughts on that, but let me hear other people first.
Well, let me jump in, Roger. I think there were quite a few presentations through the day yesterday with similar relevant findings about testing in populations where the pretest probability ranges from relatively low from Naim Al-Khoury's presentation of the validation of the AGA pathway using the NHANES data through a diabetic, mostly sort of secondary care population like this, to even more enriched populations like there are in the clinical trial data sets. And there was some thoughts emerging to me, and those were about how we either pre-select patients, how we enrich the population for testing, and if we do that, whether we still can rely on a two-step testing pathway. So the performance of FIB-4 at the current cutoffs wasn't particularly brilliant in any of those, and in the work that Sven was just talking about, Laurent Castera's work, the rule-out threshold when it was set at a sensitivity of 0.9 was less than 0.85. Now, that excludes only 20% of people, meaning that 80% of people would need to go on to have downstream testing. So if we're going to stick with the way that we're doing it at the moment to find significant fibrosis in these more enriched populations, it makes a strong argument just to go to what previously might have been considered to be a second-line test, but increasingly in those populations could, I think, be considered a first-line test. And I think that's what Mazen's been talking about when he's doing his studies on cost-effectiveness of that type of screening approach. That sort of changed the way that I've been thinking about the problem if significant fibrosis is the target. I think if we're going to be looking for disease that's a bit more advanced, so advanced fibrosis, then the two-step strategy would probably stay in place. But what the target is, the patients that you're looking for and the setting that they're coming from, I think is becoming increasingly important.
Jörn, you look thoughtful.
I think I'm aligned here. It's been a meeting that brought forward a wealth of data on the accuracy of these tests in special populations. Also, Rohit Lumba presented data from the resmetirom trial showing that if you move into a pre-selected population with high metabolic risk factors, FIB-4 is not the test to identify patients with advanced fibrosis, and I presented some of that data at EASL. So I like the approach Ian is describing. We have to fix the target, think about different situations. It's not a straight one-shot-fits-all test here. We've known that for some time, but now we get more numbers to relate to that.
That's interesting. Out of all those things, the two things I found most striking, first of all, Stephen, in your study, in the Sagimet study, how poorly CAP fared. That, I think, was
let me just comment on that real quick, because this will be made clear in the guidance document coming out through AASLD. CAP does not work for quantifying steatosis, at least the current CAP, the way that we've always utilized CAP. Now, I know there's some revisions to EchoSense's CAP measurement, but the one that the vast majority of people have around the world, it's only good for a binary yes-no. And that came perfectly clear in that data set that I presented. That's something that people need to take away from. But just thanks for bringing that up.
So that's number one. And then the second one, and this goes back to something Sven was talking about from the Castera paper. Ian, it's kind of the flip side almost of your point, which is that when he took a look at gray zone, that enabled him to do true positive and true negative. And one of the real striking findings was that the gray zone around MAST was 10% and everything else was up in the 40s, which meant that you, at the end of the day, wound up with a vastly higher true positive, true negative score with MAST than you did with the others. Now, what that says to me is that, and in fact, at one point, Mazen, I think, ran numbers in his head and said that you'd save $2 million in screen fail biopsies if you could get your indeterminate zone down the way that MAST does. So part of, I think, what we're talking about here really is, and you guys have all pointed out, is what's the problem you're trying to solve? If the issue is how to do the best job of getting the right patients into clinical trials most efficiently, the results from Professor Castera's paper would suggest that MAST really stands out. If you're talking about treatment, then I think FAST had a really good meeting in that regard as well. At least that's my sense of it. You guys tell me.
I think that's spot on, Roger. And the excitement that we're hearing about with treatment coming soon, I hope, means that I guess the focus that there has been on recruitment of patients into trials and trying to limit the screen failure rates has been important, but we've really got to think about how we're actually going to use these drugs now, how we're going to select patients for treatment, and using what tests. Jörn's right, it's not a one-size-fits-all approach, but the reality is, certainly in the UK, that trying to come up with bespoke testing strategies in different populations is only going to make things more difficult rather than easier, and I would like to see if we can try and find a unified approach that identifies as many people as possible so that they can be treated appropriately.
So, Stephen, I don't know if you heard this, but on one of the preview episodes, Ian quoted your KISS approach, except that he would not state the second S out loud on the podcast, so he just stopped to keep it simple. NAFLD around this particular set of issues. But Ian, I think that's a great transition to go from the diagnostics into the drugs. So Stephen, you take a minute and walk us through the high points of the two late breakers you presented yesterday. We talk a little bit also about Regenerate and see what we can come to on that issue.
Yeah, all right. Let me just start with the Akero data with the efruxifermin. If we have time, maybe we can come back around to another therapeutic. Efruxifermin is an FGF21 agonist, and the reason why we like it is FGF21 is an endogenous metabolic hormone that regulates energy expenditure, glucose and lipid metabolism, and so it's an attractive target. The problem with native FGF21 is a short half-life of only about 2 hours, so you've got to do something to extend the half-life of that drug, and efruxifermin has kind of a unique structure that no other FGF21 in development has, in the sense that it has a bivalent component to it. In other words, there are two FGF21 molecules linked together by an FC fusion protein. It also has some point mutations on it, and what that essentially allows you to do is there's greater affinity and stable binding to the receptor, so it sticks around a bit longer. And there's been data already presented on this from a previous trial called Balanced. It's a phase 2A trial, and in that trial, which was with any 2A trial, shorter duration, certainly less than 24 weeks, and it was all driven by non-invasive assessment. There were biopsies done, but that was not the primary endpoint of the 2A trial. But based on the prior assessment in the 2A trial, the Harmony trial was designed, which is a very classic phase 2B double-blind randomized placebo-controlled multi-centered trial of two different doses of efruxifermin, 50 milligrams and 28 milligrams versus placebo. This is actually built to be a 2-year study. If you hearken back to the Pivens trial, the last time we had a 2-year study was that long ago, published in 2010 New England Journal. The duration of the trial is pretty long. Biopsies to get in, biopsies to get out at 96 weeks, but there was an interim assessment at 24 weeks, and believe it or not, that was the primary endpoint, was assessment at 24 weeks, looking at histology, and it was driven by fibrosis, improvement of at least one stage with no worsening of NASH. So the type of patients that were put into the trial were the ones we were just talking about, the NAS of 4 more with F2, F3 fibrosis. They also had an additional gating to get in of a MRI PDFF of at least 8%. So just to jump to the chase, 128 patients were randomized, 113 were analyzed, because that's the number where we had 24-week liver biopsies. So that's called the liver biopsy analysis set. Now, that wasn't an ITT set. This was a responder analysis, but it was an a priori analysis. It was in the statistical analysis plan to do it this way rather than ITT because of the small numbers relative to the trial design size. But interestingly, in the Q&A, I didn't get asked about ITT, but we can talk about that here if somebody would like to discuss that. Baseline demographics, 70% diabetic, 70% had F3 fibrosis. And another interesting fact about the way this study was read out is it's really kind of the first time we're seeing consensus biopsy analysis. Now, I know Regenerate also did it. That was presented later in the same segment of the meeting. But the idea here is two different pathologists read each biopsy and scored each slide. And if they agreed, that was the final score. If they differed, they came together and reviewed the slide digitally over Zoom and reached consensus. If they could not reach consensus, a third pathologist was brought in to adjudicate the differences. Really quickly, the primary endpoint was met. So both doses were statistically significantly superior to placebo, and the treatment effect delta at the highest dose was 21%. For NASH resolution, there was a nice stepwise increase. Placebo, 15%, low dose 47, high dose 76, giving you a treatment effect delta of 61% for resolution of NASH at the high dose. And then just diving into that a little bit more, the more stringent composite endpoint of both fibrosis improvement and NASH resolution, building off Sven's work with lanifibranor, showing a positive impact there, 41% for high dose, 5% for placebo. And the other thing that you see here is when you go to a more stringent endpoint, placebo response is harder to achieve, so it's much lower. And then about 15 to 16% of the patients had a 2-stage improvement in fibrosis compared to 5% for placebo. So that's all that I presented on histology. When we looked at comparators with some of the non-invasive markers for fibrosis, you see very nice reductions in PRO-C3, ELF score, and liver stiffness by KPA. Liver fat was significantly reduced in line with what we'd shown previously. But building on this this idea that 30% relative drop in liver fat is kind of a low bar. We know that the more fat you lose, the greater the odds you have improvement in histology. So we wanted to look at patients that lost more than 50% of the liver fat. You see that about 63 to 77% did that. And then we looked at those that completely normalized liver fat, or at least went to less than or equal to 5%. And it was none of the placebo, 34 low dose, 51% in the high dose. If you're a person that follows liver chemistry tests, there was a very rapid and sustained reduction in both ALT and AST, dose response wise, achieving 47% relative drop or a 33 unit absolute drop with the high dose with ALT. And I think probably more important is this drop in AST. It was 28 units per liter with the high dose, which was a 49% drop, which I thought was pretty impressive. Tolerability, generally well tolerated, in line with what we see with injectables, generally mild transient diarrhea, nausea. There was one drug-related serious adverse event. It was an ulcerative esophagitis case. There were a couple discontinuations in the low and high dose group for various reasons that we can talk about if you'd like. But lipoprotein profiles were good here. Triglyceride drops were around 25 to 30%. HDL cholesterol rose around 24 to 30%. Not a bunch of movement in LDL cholesterol. It was down about 8% in the treated groups. And then HbA1c, remember 70% of these people were diabetic. There was still about a half a point drop in the type 2 subset. These are people that 14% were on GLP-1s, still seeing an additional drop there. C-peptide dropped, basically correlating with improvement in insulin sensitivity. There was a weight change, positive weight change in the high dose group of around 2.6% improvement, which we didn't see with the low dose or with placebo. So I think these data are very promising. I think it gives us enough data to move forward with this compound in phase 3. So I think you might see this be the first FGF21 that goes into phase 3 sometime in 2023. So let me stop there and see what people want to say about it.
That was a lot of data, Stephen. Congratulations.
Yeah, I think it's a team effort, right? A lot of work done by a lot of people to put this together and bring it forward. And we had a lot of promise and hope in FGF21s. And I think the first time around, we were a little disappointed with what we saw with pegbelfermin. And there was some current concerns about tachyphylaxis. A lot of that has been put to bed. And maybe it just reflects that not all FGF21s are created equal. And the target is a good target, but you have to structure your chemical entity appropriately to have sustained binding so, that it sticks around long enough to do something positive. The other thing I didn't mention here is the target engagement. There actually is a marker of target engagement for this class of molecules, and that's adiponectin. That went up significantly. And there was actually a separate poster here. Sven, it was the lanifibranor data, right? Where upregulation of adiponectin of more than 60% actually correlated to improvement in histology.
Absolutely. And I think you also hit a very important point, Stephen, that is that not all these molecules, although they belong to the same class, are created equal. It's really about receptor engagement and then downstream targets activated or less activated. All of these compounds in all of these classes can have a slightly different profile, but that can have substantial impact on the overall results.
So my question here, Stephen, I'm not sure, is that related to how that agonist binds, or is it related to the pegylation and the PK and the extended availability if you look at other FGF21s?
Well, they're all they're significantly different. Pegbelfermin is a pegylated compound, and it didn't stick around that long, actually. The efruxifermin is once weekly. It has a relatively long half-life. This bivalent structure of that, there was actually a poster 5051, if you want to go back for our listeners and take a look at it, that dives into this bivalent structure a bit more. That's maybe the secret sauce to that entity, is it really allows for stable binding, and it allows it to stick around and have its action for a while. And we don't have anti-drug antibodies yet from the BALANCE trial. It's something that, of course, is being looked at closely, but if you are from the HARMONY trial, but if you go back to the BALANCE trial, we do have the ADAs. And while about 70% had anti-drug antibodies, antibodies. It was a very, very sensitive assay, but there was low titer. They were directed to EFX directly, and it didn't seem to impact adiponectin expression. So if you look at ALT trends here, the rapid and sustained out to 24 weeks, we're not seeing a rise towards the end of that. Same thing with MRI-PDFF. So, we have to track that out further. It'd be interesting to see what the 96-week ADAs look like for tachyphylaxis, but at least at 24 weeks, I don't believe we're seeing what was seen with the BMS compound.
Stephen, would that imply, forgetting about 96 weeks for a second, one of the questions you were asked yesterday and answered, we've talked about this some on the podcast, is the right use for a drug like this, which might be induction therapy. Will the 96-week result actually affect its appropriateness in induction therapy as compared to longer-term or maintenance therapy?
Well, what's going to be important, Roger, to see, are we able to keep these patients on drug out to 96 weeks? If you look at any injection, I guess claims data from the GLP-1s, people tend to fall off the wagon over time. They're not renewing their medications as frequently. I don't know the exact number, but I've seen data, if I recall, around 50% drop off at 1 year in people that are continuing to take these injectables. So obviously studies are a bit different. We're more stringent in our follow-up, and hopefully we have most people stay on drug. My initial impression of the way we'll use these injectables is probably more of short-term use and use it more aggressively in people that have more advanced disease and try to get them under control and then switch them over to a better tolerated, longer acting oral, or not longer acting, but a drug that could be used for the long haul that people could tolerate better. So maybe I'm a little myopic in that opinion. I'd love to hear my colleagues' views.
I think it's an excellent way of thinking. What we are not knowing for the moment yet, if we have a substantial improvement of the liver condition and a kind of reset, how quickly the disease reappears if the metabolic driving factors are still there. That's an unanswered and I think very interesting question, but only from experience with patients, you sometimes have the impression that some of these patients have quite good reset of their disease, and it takes quite long before they regain indices of more severe liver disease, although the treatment has been stopped and they still continue to have overweight and diabetes. So the dynamics of what happens when you have reset the disease to a point where there is far less liver damage and activity is still an unknown to me, but an important thing to investigate.
No, I think we have to await for that data, and the anti-drug and that class are, of course, something that we'll have to look for. I was compelled, and I asked you that question, by the low placebo response when you actually go for the more stringent endpoints. And if you talk to EMEA these days, it's something they're still looking at, and it's achievable. That's the other thing in this phase 2. You get a 36 to 40% difference in treatment versus placebo. So I found that was very interesting. Kind of the same way what Sven says. I mean, patients are doing things. That's why I was wondering, what are the predictors in these patients that respond to placebo hitting both of these endpoints? And that's probably weight loss and change in lifestyle. That might not always be captured in all cases, I guess.
Well, we do know that at least we did do a subset analysis on weight, and that didn't impact here. There was 14% of the people on GLP-1s. That didn't impact. 44% were on statins, and you do a responder analysis on statins. That didn't impact fibrosis improvement one way or the other. I just think we need to continue to mine the data a bit more, but it's certainly a very positive class of drugs to continue to look at and figure out where we're going to put them. I think Sven's comment about how quickly this comes back is a good one, and the only insight I have from that is one of the trials we did with aldafermin and NGM, we actually had 6-week follow-up MRIs. We saw some liver fat coming back at 6 weeks, but what was completely flat was ALT. So to your point, we might take a while to reset the underlying inflammation and damage, even though maybe isolated steatosis begins to filter back in.
Just another important point to come back to Jörn's comment about the combined endpoint. I think that makes a lot of sense because you can have, of course, regression of steatohepatitis, and it may take longer to have an impact on fibrosis, but the other way around, having a substantial impact on fibrosis without having an impact on steatohepatitis is quite unlikely, and only if you have really pure antifibrotic targets. And even with the obeticholic acid, although it did not hit the endpoint of NASH resolution, there were improvements in the features of steatohepatitis. So I think combining the two substantially reduces the placebo rates and gives a more comprehensive view on what is really happening and on the quite intimate link between steatohepatitis and fibrosis. So it makes absolutely sense to combine these two endpoints into one combined endpoint.
So with that, why don't we leave efruxifermin, spend just a little bit of time in Regenerate, and then go on to whatever else we wanted to cover. Regenerate, basically, I'm going to summarize at a very, very high level. They're up to 2,500 patients. The data that Arun reported yesterday was based on a change in the reader. For the 2019 trial, they had two readers. They randomly assigned slides to one or the other. For the 2022 version, they used the consensus method, right? The same kind of thing that Stephen was describing before, with the idea that if they couldn't adjudicate, they threw out slides. One of the things that I think Arun said yesterday, if I heard him correctly, is that 10 to 15% of the slides wound up, they couldn't get aligned on them and they wound up not using them. Did I understand that correctly? It was 10 to 15% that went to adjudication. I might have gotten that wrong. I was a little confused about that.
I think that was more of a gestalt answer. I don't think he knew the exact number, but there was a percentage that couldn't be interpreted.
Yeah, and that percentage, I mean, we do not want to lose that data, right? So patient gave the liver tissue, they underwent the trial, and that's where we need to augment the reading by 2 or 3 histopathologists who can't agree using some technology that brings us to a robust and final score. That's my thought.
I agree, and I was struck by that number, but one of the things I was struck even more by was what the effect of the number was. So Stephen has argued forever that placebo response rates are the thing that might be affected most by reading strategies, and the most striking thing, I mean, these numbers all clarified with larger sample, but the only thing that dropped was the imputed placebo response rate from 2019 to 2022 went down from 12% to 9.5%. At the same time that the F3 reduction in fibrosis went from 22 to 25. Now, neither of those is in and of themselves a big difference, and all it did, the statistical significance coupled with sample size, was moved it from 0.002 to 0.001. But on an optical significance test, 11 versus 22 and 9 versus 25 look vastly different, at least to me. You know, one is 2 to 1 and one is almost 3 to 1. That was number one. The second thing that struck me from Regenerate is at the time it wasn't approved, much was made of the LDL increase. And the question was it going to resolve over time or not? And I think what demonstrated yesterday was that it did resolve over time, right? So if the two issues with the drug were not that great, even if it hits efficacy endpoints, it wasn't striking, and that there were safety issues largely around LDL. The LDL resolves. The efficacy data looks better for 25 milligram than it did. And I'm going to ask you guys, because you know this and I don't, what else should it take to get this drug approved at this point? And did yesterday's reanalysis make in your minds, a significant contribution to that effort?
Well, I won't pretend to read the FDA's mind. I mean, at the end of the day, people that try to do that, are proven wrong more often than they're proven right. I think it all comes down to the therapeutic index, and is the juice worth the squeeze, the view worth the climb? And the treatment effect delta on fibrosis is stat sig. Is that clinically significant? Well, I mean, we don't have any treatment for NASH, so you could argue that if 1 out of 8 patients is having a positive impact, that's more than what we're doing today. So in theory, I think it would be good to get that drug approved, even if it just has, a small subset of the population that's responding. Having said that, I do think we have a ton of safety data now, 8,000 patient years of data, 1,000 patients have been treated for at least 4 years. Yeah, we're going to have some issues with gallstones. We're going to have to send some people to cholecystectomy, but I think in the right patient population, and I say that to mean non-cirrhotics, that there might be a role for this drug, at least early on, until we can get other therapies that are more effective and hit more extrahepatic benefits. But I think the data that came out yesterday helped their cause. There's a lot of questions. I asked the question about, these are 3 new pathologists that read the data set. So I asked, did you reread baseline? Because if you reread baseline, you're going to throw out a whole bunch of people that aren't called NASH, right? That just happens. And the comment that Arun made is that they weren't reread. The baselines were not reread. They just read the end of treatment. So I had questions about that because it was 931 cases, again, that were read, but I thought some were thrown out. So I don't know if the full 931 actually were included in the analysis. So there's still some little minor questions I have about the methodology and how we got here, but but just at a high level, I think they helped their cause yesterday.
For me, there were two things. And first of all, I'm not sure that they did not look at the baseline biopsies. I just think they did not make the comparison in terms of diagnosis between what was read before and what was the reread now. But I think they looked at both baseline and end of treatment biopsies, but just for the comparison. But I'm not sure. I was not involved either.
That would make sense.
The first thing is, although some of the absolute numbers changed, if my memory is correct, the effect size was more or less the same compared to the first read. And that's, to me, one of the first messages. You can discuss about biopsy and inter-observer variability, but if the biopsies are read in the same way, baseline and after treatment, whether it's by one pathologist, two pathologists, the stringent process that Stephen described for the Akira compound, or whether it's even a machine-learned approach, that the important thing is that they are read in the same way, and then you end up with more or less the same effect size. And you might have differences if you just make cross-sectional comparisons and diagnostic comparisons cross-sectional. But if you compare pre and post-treatment, you end up with the same effect size. So that's quite reassuring and quite substantial support for their cause, but also for other histological readings. And it's also for, Stephen, you have very compelling histological data with the Akira compound, but I think this kind of analysis also helps reinforcing that these data are reliable and important data, and we should not always question the liver biopsy if we have a stringent process to analyze the biopsies in the same way pre and post treatment. And the second point is, indeed, I think with the fact that you have an impact on fibrosis regression that is confirmed, but if you look at the overall picture with those that worsen and stabilize, you get again that this compound helps you to slow down the progression of the disease. And it's not always powerful enough to have fibrosis regression, but another bunch of patients have a benefit by just halting progression of the disease. So as long as we do not have very effective other compounds that can help us improve that condition, I think this would be really a valuable asset to treat our patients and at least halting disease progression.
So with that, then let me try to do two things before we get out of here. Ian, if you'd like to cover one of the things that you prepared this morning, and then I want to let Jeff go to nomenclature.
Okay, well, I was going to talk about disease identification, the work that Alina Allen's done with the AI-GI team at Mayo Clinic Digital Solutions for NAFLD diagnosis, and that sounds great. I'm all for not seeing patients, but telling them that what's wrong with them. I think we all know what the problem is, and that is that despite high disease prevalence, prevalence of disease diagnosis is much lower. And the question then comes about how best you find the right people to see and then to treat. And what Alina and the team at Mayo have done is to build machine learning tools to enable prediction of the NAFLD phenotype, and they've done that based on coded diagnosis in their large health system. And so they've got about 100,000 people with a coded diagnosis of fatty liver disease, and what they did was then to match those to a set of age and sex match controls matching 4-to-1. So for every one patient with NAFLD coded diagnosis, they had 4 patients without NAFLD. And there were a few interesting things that come out of that before you even think about the machine learning approach, and that is that the number of diagnoses that the NAFLD patients had was slightly more than the number of diagnoses that the 4 times as many control patients had. So that highlights the links to multimorbidity and the other metabolic conditions that these patients likely have, and the fact that these individuals who've been diagnosed with NAFLD are already in the hospital systems, and probably that means that they're systematically different to the control patients. And there was a similar observation for the number of lab tests and medications that those patients had or were taking. So they run their machine learning algorithms. I won't pretend to understand what those were or how they were developed, though the processes sounded like they were done in a robust and systematic way. And they highlight a sequence of features. So the difficulty with looking in health records is that there are many thousands of potential features, and they compress those into features around clinical diagnoses, around investigations, and around the medications. And the top features that they found were probably not that surprising. Age, metabolic lab parameters, ALT, AST, TSH, which may be a bit surprising, but that's the beauty of doing these analyses, is it allows you to uncover patterns that you might not otherwise see, and alkaline phosphatase. And I think that many of those are things that we're already thinking about using in our practice for identification of patients, and how you put those together, and finally then how much better that algorithm is than simply looking for patients who've got obesity or diabetes or an abnormal ALT and some other risk factor. That will ultimately, I think, become the big question about how we find those patients. But their algorithm performed pretty well in their validation subset, patients who had a code. And then the other other thing that they did was to look in the patients who had a diagnostic COVID NAFLD, but looked back in their records before the time of diagnosis to look at liver fat on identified imaging reports. And again, the algorithm works very well, but it's still in that same patient population. So I think this is a really interesting approach, a way to automate identification of patients who are at highest risk of having NAFLD, and so that they can have appropriate downstream testing. Needs external validation in cohorts that don't come from the Mayo Clinic. I'm not sure that the Mayo Clinic is entirely typical of any other healthcare system in the world, but those patients are, of course, very well phenotyped and allows this sort of work to be done. And then once that external validation is done, and I hope is successful, then we'll be able to begin to think about how we really go about identifying patients in the primary care and indeed in secondary care for treatments.
Okay, so let me just ask Jörn or Jeff, who we've heard a little less from today, if either one of you has any thoughts about that.
I agree with Ian that this is an interesting abstract and stimulating to think about. We've done similar work trying to identify those patients. The point you made, Ian, is of course they are somewhat in the system already, so cases that are not even included in the medical system will be missed. But I think the technology advancements that are available could be used to identify patients that are overlooked and link them to care. And as such, I do like that approach a lot and be happy to see what it does in my database and see how much many more cases could be identified. So overall, I do favor these approaches.
Yeah, I would agree with that, Roger, very quickly. And just saying that probably the biggest point I would agree with Ian on is that Mayo Clinic isn't representative. And I would be curious, at least domestically here in the U.S., acknowledging the issues with it being government, but if there was any way to be able to use this through for instance, like federally qualified health centers to be able to use that sort of data to be able to better identify as well.
That's interesting. Jeff, share with us some thoughts that you might have about nomenclature.
Yeah, thank you, Roger. This session was live streamed, and I'm not sure how many of the sessions. I know there was a virtual component to the liver meeting this year, but I know this was live streamed, and so hopefully folks were able to see the session, to be able to sit through the session and whatnot. I don't know how many of them got a glimpse of our nomenclature pigeon, but hopefully a few were able to see that as well. So the session was, as I understand from the back of the room, kind of a report out of the second Delphi round of survey and consideration of the name change for NAFLD and NASH. I'm seeing from the notes here, 264 global experts, 56 countries. They got 54 respondents from roughly 32 countries. And so they've done a good job of getting kind of a broad swath of country and global representative in this. Two sessions, certainly Mary Ranella and Phil Newsom have been kind of the leaders charged with trying to herd the cats to get everybody together. And by cats, I mean clinical researchers, to kind of come together on what a name change, if it needs to be, what it should be, what it shouldn't be, et cetera, et cetera. And so from the patient perspective, let me throw a couple things out here. I know Sven's already kind of gilded the lily by talking about excitement and movement in that area. And I think I will have to respectfully stand in contrast to that from the patient perspective. And I know that Donna has, who is my boss to call that out, and Robert also were given 5 minutes in the 2-hour symposium to be able to kind of speak to some of their concerns. There were some things that were lacking that were alarming to me. Let me emphasize the positive first. One positive is that from both of the panels, it does seem like there was a presentation, then a panel, presentation, and a panel in the process. And it does seem to me that we are beginning to move away from MAFLD with an M, with metabolic associated fatty liver disease. That was kind of how this all started. It wasn't as much that we came up, with a journal article from Australia. It wasn't as much that it was that NAFLD needed to be changed in a vacuum as it was that NAFLD needed to be changed to MAFLD, that metabolic needed to be the name change early on. And I think we've moved away from that in a recognition for as much of the semantic difficulties that there are with non-alcoholic by defining something by what it's not and how tricky that is. But to move to metabolic didn't necessarily solve any of these definition challenges. It was still overly broad. Nobody could kind of put their finger on what that meant in a way that would be clinically significant or helpful or any other myriad of kind of downstream implications that would be positive for the field. And so I was fairly heartened by that. I don't think we quite got there. There were still some defenders, still some believers in metabolic there. What I felt like we were beginning to come at, and this may be the movement that Sven was talking about, is Quentin's. I think I first saw Quentin talk about this in his stratification, if you will, about referring to it now to SLD. And I wasn't quite sure if that's, just referring to steatosis or the steatohepatitis, but just kind of refining the name and then having kind of these subcategories and how those subcategories would be named, whether it's type 1 or alcohol-derived or fatty liver, kind of how it is was still up in play a little bit. And so that said, that's the best objective reporting I can kind of do on that, is that there was movement, there was good conversation, there was a discussion. I think we kind of got to that place. I'm not sure what the next steps are. Jeff Lazarus in his presentation seemed to indicate that there might be another Delphi round of surveys coming forward. I didn't have a good feel for what the next step in that was going to be. Let me represent respectfully, if I may, my considerations, the concerns that I had in the back of the room. There were a couple of things that were not mentioned that I think were really important in this. When you look at the process to begin with, the process when Jeff was detailing the respondents, for a supermajority, as they said that they had decided that they needed to move forward in any aspect of that, you needed 66% of the respondents to be able to kind of sign off on that. We see that in Congress all the time here with the difference between a simple majority and a supermajority. Certainly it's something we're familiar with. What concerned me about that is when you looked at who the respondents were, roughly 72 to 74% of the respondents were clinical researchers, with only 12% of the respondents being patients. Now, I wouldn't have a problem with that if the meaningfulness of those responses were proportionately powered. But that's not the case. And so there is a situation, I'm not sure that this will happen, but there is a possible situation to where this name change could move along with only clinical researchers moving this. And there has been a little bit of input here and there, but I don't feel like it's been powered or adequately represented in a way that will be reflective, in a way that's going to be helpful for the field writ large. Things I did not hear at the nomenclature meeting. One was any mention of the FDA, and I think that's extremely problematic. When Joe Turner came out and said at NASH earlier this year that if there were a name change that implied any sort of definitional change, even if it's a restricting or expanding or anything like that, then that meant that those that had in clinical trials that had money tied up in this, anybody that was vested would have to then go and revalidate all their indicators and biomarkers. Now, that raises the question of timing for me on this. As I've met with Global Liver Institute, with several of the drug developers and several of the companies, we have the potential for an asset, a therapeutic, to roll out as early as 2023 next year. But, we talked to probably a dozen companies plus while we were at the meeting here, and we see that there are, in the most optimistic of worlds, which I realize isn't necessarily realistic, but in optimistic of worlds, there are phase 3 and phase 2 rollouts that could potentially go up for approval or accelerated approval between now and 2030. Multiple drugs could be coming to market in that time frame. But if there's a name change and there has to be revalidation, then that suddenly time frame becomes very different and has to be reconsidered in that. Part 2 of that, which is kind of a continuation of that, is I haven't seen or heard anywhere, and I'm one of the folks participating in this process, any notion of an impact analysis. And I appreciate that people have opinions and are speaking from their own individual experience about things, but I would really love to see, and it just kind of boggles me that there hasn't been promoted an impact analysis of what would a change of name mean, on an economic level, on a communications level, on a level of understanding. There is the linguistic necessity that I completely understand and sympathize with. As someone with a master's in philosophy that used to argue about words ad nauseum, I get that. But when we're talking on the edge of drug development and we are on the edge of really making some big leaps in terms of awareness and communications, I have to question the timing of this and if this is the most important thing for the field to be dealing with in this. Donna raised the issue a little bit. I guess I'm echoing my boss a little bit on this as well, but the timing seems suspect to me, or seems like it could be done better, if you will. A decision, does this become do we make the change at the next AASLD or next EASL, or does this something that kind of slowly rolls out over the next 2 to 3 to 4 years? Do we do it after a drug potentially is approved, before a drug is approved? And then what are the consequences over that? The final thing that I'll mention on this too is that I was in the room, and unfortunately I think this is the patient experience, the patient perspective of that. We brought in several patients. I was in the back of the room with a lot of actual liver transplant recipients, and they just had no clue what was going on. Several of them were leaning over or texting me at times like that and really wanted to go up and say something, but that was a massive room, and it was the video screen was really intimidating. Maybe this is why we were also keyed in on the pigeon. But 3 of them came up to me in a meeting later on and said they really wanted to get up and say something about how much of a waste of time and resources they felt like this was, but they were too scared, and said all these other people were talking in these fancy medical terms and they were concerned about getting up there and stuttering and not making the point that they wanted to make. And wow, that is the patient perspective and the patient experience in a nutshell, of being intimidated and scared to put your concerns in front of professionals and in front of the field. And we're working on trying to build that up, with GLI. The last thing I'll leave you with is that in Washington, we have a phrase of you can do the right thing the right way, you can do the right thing the wrong way. Consequently, you can also do the wrong thing the wrong way, which kind of takes care of itself, but you can do the wrong thing the right way. And we see too many people in Washington do that, which means that you take a issue or perspective, but then you're able to do it in a process that builds consensus, that incorporates all the ideas. And it may not be something that you agree with, but you've gone through such a process that everybody buys in, you understand the consequences, and it does not, unfortunately, the nomenclature process so far, without any statement on what a name should be or any of that sort of stuff, it just seems that it has been, I'll just say it was a disappointing experience.
Jeff, I want to let anyone who has to jump off this call comment on that first, and then I'll come back to it, because I think there are a couple of things you said that were, if not handled directly, were handled indirectly in ways that made me feel better about the outcome than I might otherwise have. But I know, Stephen, I know you have to jump. I don't know about the other opinion leaders here. Anyone have any comments on that?
Yeah, sorry, guys. I've just got to jump real quick. But Jeff, let me just say, I love your passion and your advocacy that you bring to this discussion. It's a breath of fresh air, and it's something that we need. And I'll be the first to say that I often don't remember to include that. So it's great to have GLI as part of this process. And we're not perfect. We got a lot of work to do. The butter slides off our biscuit every day. We've got to include that in this process. I do think this idea, steatotic liver disease, is the kind of the overarching buzzword that's being tossed around. What comes under that and how we develop it, it's not defined, I don't believe, fully yet, and there's still more work to go. So continue to do what you're doing, because it will resonate and just continue to be the hammer on the nail. So let me just say that.
If I may, because I was quite involved in this process, and it's interesting sometimes to see the dynamics of such a process. For example, the overarching term of steatotic liver disease was something that I have put on the table. We need probably to be more broader than just talking about NAFLD and get the bigger picture. That was a little bit put aside in the beginning because most of us felt that we should focus on just NAFLD, metabolic, and so on. But then later on, it came back. Maru Rinella picked it up again, and then Quinton presented it in one of his presentations. So you see how this can evolve over such a process. Now, you have said several things, Jeff. What I think, and Jeff Lazarus also said it in the beginning, one of the important things in such a process is, of course, the representativeness. Although the majority of people that are in the Delphi panel are indeed physicians, most of them are hepatologists, the process does include strong voices of non-hepatology experts, like yours and like GLI, like also the pediatricians, the endocrinologists, who also may feel a little bit underrepresented if you just look at it from a pure democratic one person is one voice principle. But that's not how it goes. And you're absolutely right that we have to be very careful for the next round, which will be probably what is going to happen, that now that we narrowed down a few issues, that we see where the remaining issues are, the questions in round 4 will have to be formulated very carefully to make sure that what has been put forward as something that needs to be taken into account in the final solution is taken into account. And some of the issues that people like Donna and Robert have raised on the podium, and that some of the people with you in the back of the room apparently also felt, I think that is something that is absolutely important. And it's not just being a percentages of the voices that will be decisive whether it has an impact or not. It will clearly be a huge task for those who are preparing the round 4 to make sure that all these concerns and all these important points are adequately captured in the round 4 questions, so that they are really valued for their importance and not just put aside by the power of simple numbers. So that's I think a very, very important point.
Okay, thanks, Sven. Ian, anything you want to add? I do have a couple of comments.
Just 2 things I think that I would say. First is that there is people using an alternative definition already, and there's a real risk, I think, to that fracturing the field further, leading to more inconsistency and more uncertainties. And the other side of that is that where people have already begun to use an alternative term, I'm not sure that a supermajority is sufficient to really say that there's consensus, because I suspect that some people have already made their mind up about what their preferred term is, and that's going to be the real challenge at the end, is to make sure that everybody really does get behind it. And there are risks to all sides of that. The final thing about steatotic liver disease is that if you look worldwide in terms of disease importance, I'd argue that steatotic liver disease, number one, is alcohol-related liver disease, and there are also risks to changing the structural definitions around another disease where that community is not yet involved in the consultation. So the work that's been done is really impressive, and I've been pleased to be a part of it, admittedly a smaller part than Sven and Jörn, I think, have been involved. But there's still a lot of work to do, and the impacts and downstream consequences of a name change need all to be thought through in some of the ways that you've talked about, and others too.
I'd like to echo what's been said, and I think the phrase that resonated with me here, Jeff, being a part-time politician or having to use work in policy, is you can do the wrong thing the right way, and then it sticks, and you're bound to it. And I think we do not want to get point with no return, where there's something that the field will take a big hit on over a long time. And the questions you raised about the consequences, I'm not sure how to model that. That's a tough one. Nobody can look into the future. How is that mean going to drop off of perception with other professionals and so on? There's just a lot of complexity to that. So we'll probably got to take a couple more rounds on this.
Yeah, I think that sounds right. So first of all, I have no horse in this race at all, right? I'm not a patient. I'm not an advocate. I'm not a physician. But I have been observing. And a couple of things. First of all, Jeff, you pointed out, I think correctly, that this started as a specific name change to go from NAFLD to MAFLD, and not just a name change, but a patient definition change. And one of the things I think I heard this week that's really important is that there's no appetite anywhere to change the patient definition. So the questions about commercialization and are drugs going to slow up and diagnostics, nobody wants that. Well, let me amend that. The overwhelming consensus of the group was that was something the group did not want. I mean, that scored 85, 90% all the way through, which even if it's only clinical researchers, I can't believe, apropos of Donna's comments, that patients are going to want that any more than this group does. So if we're only talking about the name, not to trivialize the importance of the name, but the issue of are we going to slow progress on drugs and diagnostics, my sense of this conversation is that will be protected. Sven, you're a lot closer to this than I am. If I've got that wrong, please come in immediately and say so, because that's important. Beyond that, I'm a big fan of dynamic systems and system dynamics, and I think Ian did a really good job of explaining the other side of the dynamic problem here, which is if you do the right thing the right way, and in the process, everybody who doesn't like where it's going jumps off and does what they want to do, then what we've accomplished is we've now got dueling names and dueling dialogues. My sense is that at some point, even if it's not exactly the right way to get there, someone's going to need to plant the flag and play forward, because if not, then this could devolve a lot more. So if we go 3 more rounds before we get to an answer, and every time we go another round, 5% of the population or 10% of the population leaves the tent, by the time you get to the 5th round, the tent is maybe half the room. So there is this risk that waiting for Quentin's the one who always says, let's not let the perfect be the enemy of the good. And here, I think we've got to decide what good enough is, or you've got to decide. Like I said, I have no horse in this race, but the question's got to be what's good enough. And then I'm going to come back to a very, very funny place. And Jeff, I hope your boss doesn't shoot me for this, but it's a conversation that's been in the background this week among several of us. In 2021, at the NASH Tag sessions, Mike Charlton asked a question, which is who's going to be the Larry Kramer of NASH? And that's gone in a bunch of different directions. But one of the places I think that it went is, I know Donna and I have talked about it a bunch since then, is I think the firmness of Donna's advocacy for a couple of things that really mattered to her on this, notably the let's not get in the way of progress, has, I think, really resonated. It wasn't something I was hearing at the beginning from folks, and it's something I've heard increasingly as we've gone along. So to the degree that is that kind of role, that is being on the inside and being an outsider at the same time and saying, hey, let's focus on what really matters here. And I think the firmness of her statement this week and the agreement that the group has speaks to the idea that that's now a thought in the middle of the process. And to the degree that Donna was the one who brought it there, that is exactly what you want patient advocates to do. And my hat's off to her every day. You all know that, but my hat's really off to her on this one. Okay, simple closing question. The 2 most important things that you believe will change by the time we get back here next year. Okay, I'll go first. Number 1 is I think we will be well down the path towards having drugs in a year. If we don't, we'll be way closer to that.
That resonates with me too. I think with the drug development arena is a critical step closer with FDA decisions based on the available OCA data with more safety we saw and the drugs that Stephen presented. I think we're moving full speed ahead with drug development in that arena.
So then I'll do the second one, Jörn, because it falls actually off of the first one, which is that with that comes investment, and with investment comes the phenomenon you described of increased spending in education and outreach to all the various stakeholders. And we will see the practical focus on what to do elevate, because money will come in the belief that drugs are coming. We kind of saw that start 3 years ago, and then, the OCA didn't get approved and things went away, slowed up for a while, but I think that's coming back with a vengeance. And I expect in a year this will look very different in that regard as well. well.
We would all be hard-pressed to disagree with the drug analysis that you've put up, Roger. That was certainly the first thing that popped in my mind, but I'll build on kind of the last bit you said there, which is to be a little bit of a homer. GLI just released a report, which I'm very proud of, called Liver Health is Public Health, a global prevalence report that's on our website, gli.org. And it really takes a look at chronic liver disease across continents with individual countries used as case studies, if you will, about what's going on in those studies. And I think what we'll see, perhaps related to potential drug rollout or FDA sort of movement on this as well, is more education, more awareness, and frankly, more countries, more underrepresented populations in worst case scenarios, not just with the drugs, but with the movement in terms of screening and technologies, being able to screen more and being able to get more people tested and hopefully to be able to get more people into a care pathway as well. I'm hopeful and optimistic when we come back next year that we'll be able to talk about the gains that we've made worldwide in that.
Fantastic. Other comments?
I don't have any other insights on. I think we're looking forward to next year. It'll be new drugs and better approaches to testing. I think that was the clear direction of travel, and we saw lots of good data again here.
I think there's a lot going on about holistic approaches, multi-stakeholder approaches worldwide. So I think that's an evolution that is clearly going on with other fields of interest, endocrinology, diabetology, obesity, primary care physicians, together with the very important contribution of the patient advocacy groups. I think things are really changing rapidly now. So it will be a different world in a year from now.
Okay, so with that, let me thank everybody. We have some far-reaching conversations on this podcast, but I would say this one is going all the way from hither to yon and back again. Lots of focus, lots of perspectives, and thanks everyone for your contributions. To our audience, stay tuned. We have an interview that Stephen and I conducted with Michael Corman, the Chief Medical Officer at Inventiva, about some of what they're up to. They are, as you know, sponsoring this episode, and we will be back next Monday to bring in, Jörn and I will be back with probably a different cast of characters to take a different look at, for people who haven't commented, we've been here on what they see in this conference at large. Until then, everybody, there will be no business report today. There will just be the interview with Michael, and then we'll be out. So stay safe, surf on. We'll see you next week. And Sven, Ian, Jörn, Jeff, thank you so much. Stephen, who's not here anymore, thank you so much for being with us today. Bye-bye now.
And now the Surfing NASH interview with Inventiva Chief Medical Officer Michael Corman, Stephen Harrison, and Roger Green.
So today we have a special interview with Dr. Michael Corman from Inventiva Pharma. Michael, good afternoon.
Good afternoon, and thank you very much for having me.
And Stephen has been good enough to join us for this. Stephen, good afternoon. How are you today?
Hey, I'm doing great. Thanks for having me back.
Always a pleasure. We're heading into AASLD week this week, so I think everybody's schedules are a little bit crazed, and everybody is tremendously excited about the meeting. And Michael's going to talk a little bit about Inventiva Pharma and lanifibranor for those in our audience who do not know the company. I'm sure everybody knows the drug. But Michael, before we get started, just take a minute or two and introduce yourself to our listeners. Tell us a little bit about yourself and your history. And when you're done, one fact about you that we might not know if you didn't tell us on this podcast, and it can't be the one I'm going to tell immediately, which is that Michael now lives one town away from where my wife grew up. So we're familiar with a lot of the same geography. Michael, you're up.
Thank you. So about myself, I'm a gastroenterologist, hepatologist, and I've been working roughly half of my career in academia in Amsterdam and the other half in the pharmaceutical and biotech industry in research and development, mostly in the field of immunology, autoimmunity, and corresponding diseases. I live in New Jersey, as you know, and something about myself that you don't know. I like to ski and to hike, so I'm very much an outdoor person, but I also like the fact that I live near to New York City, giving me all the cultural opportunities.
That's excellent, and a wonderful introduction. Michael, I'm confident our audience knows a bunch about lanifibranor as an exciting drug in fatty liver development pipeline. We've talked about it several times on the podcast. In fact, it probably comes up in some form or another once every 2 or 3 weeks. But I'm not sure everybody knows very much about Inventiva Pharma as a company. So to get started, can you just take a few minutes to tell our listeners about the company and your background, how you came to join it, and your role in it today?
Sure. Inventiva is a small company, but growing. The company has been around for 10 years. We actually had our 10-year celebration a couple of weeks ago. It's a spin-off of Abbott. Originally, it was the research site of a French company called Fournier, which went together with Abbott. The company is based in Dijon, France, and in the US. Our teams are really spread across France and in the US. And the company focuses on the discovery and the development of oral small molecules for novel treatments of diseases with an unmet medical need, including NASH. So we have expertise in nuclear receptors, transcription factors, and epigenetic modulators. We have a total of about 110 employees, and the majority of them, about 80 people, are in our scientific team. So that's the company in itself. We have a pipeline of compounds. We have Odipersil, which is in phase 2 clinical development. It's a compound for a rare genetic disease, a lysosomal storage disorder, mucopolysaccharidosis 6. And based on very positive interactions with the FDA, we are looking for a partner to co-develop this compound. We have an active discovery program in Dijon in oncology, and the most advanced compound in preclinical work is focused on YAP-TEAD as a target in oncology. And then, of course, our lead compound is lanifibranor, which is in phase 3, which is a pan-PPAR agonist and has received breakthrough therapy designation from the FDA. We have a current partnership with Sinobiopharm, an affiliate of Sinobiopharm CTTQ, which has recently acquired the rights to develop and potentially commercialize lanifibranor in China. So much about an introduction to the company.
Okay, that's great. One other thing we like to ask people when they come on is what you see happening for the company, or where the company aspires to be, say, 5 years from now, to the degree that you can answer that question.
Well, in 5 years, we see ourselves closer to our goal, which is to make lanifibranor available to patients as an effective oral therapy for patients with NASH in the US and elsewhere. So our focus is really on our current phase 3 study to realize that, and we're very positive about that. That will also give the company overall broader footage, which will enable us to continue to drive our innovation in other areas as well.
So we're going to come back and talk about the phase 3 study. I think what we'd like to do with most of the rest of this conversation is walk through lanifibranor and some of the clinical development highlights and issues as we've gone along. Why don't we start with your phase 2 work, the studies, the New England Journal article, native study design, and anything you think folks should know about that, and other key papers or presentations over the past year that have taken advantage of that data. And then after that, we'll have some questions from Stephen and maybe from me, and then we'll go on.
Yeah, sure. So the phase 2 study is called the native study. That was our phase 2b study in patients with NASH. Patients had a degree of activity defined as inflammation and ballooning degeneration. And with regard to fibrosis, patients with cirrhosis were excluded. It was a treatment duration of 24 weeks, so about half a year, and we tested 2 doses of lanifibranor compared to placebo. And it was a liver biopsy taken at baseline and at end of treatment to evaluate the efficacy based on the surrogate histological endpoint. And in addition to that, a considerable number of serum and imaging markers of liver injury and of cardiometabolic health as well. The study was mainly run in the European Union, in Europe, and in the United States, and there were more than 200 patients enrolled. So that's the study design. The data, to come to your question about the New England Journal of Medicine paper, were published last year. We were very pleased with the acceptance, of course, New England Journal of Medicine. The data of natives showed essentially that lanifibranor has beneficial effects on a broad disease biology of NASH, both the liver manifestations of and also on the metabolic immune markers that at the same time are also risk factors for cardiometabolic health. Now, the New England Journal of Medicine paper covers mainly the liver histology and the liver tests, and also the favorable safety profile. The patients that were enrolled in native, I think they were typical for patients with NASH. They had a typical metabolic profile. 40% of them had type 2 diabetes. And the highlights of the data, lanifibranor showed a significant improvement in histological endpoints. And I'd like to point out that the endpoint NASH resolution, which is improvement of fibrosis and ballooning degeneration, and improvement of fibrosis compared to placebo, was clearly met. Lanifibranor showed clearly superiority compared to placebo on that endpoint, which is a high bar, certainly after 6 months of treatment, and also, I think, very meaningful for the clinical perspectives of lanifibranor treatment. And in addition to the histology, we had a number, as I mentioned, of non-invasive serum-based biomarkers, which also show that there is an improvement of markers of liver injury, of inflammation and fibrosis. And based on these data, the FDA granted breakthrough therapy designation. So that's a summary of what the New England Journal of Medicine paper contains. And as you mentioned, we have in the past year and a half presented additional data, which are essentially analysis of the native data. So while the New England Journal of Medicine paper focuses mainly on the improvement of the liver values, these analyses include, for one, just as a couple of examples, an application of quite stringent statistical methods to identify non-invasive biomarkers that predict histological response. And that work has been done in collaboration with Dr. Boursier at the University of Angers and was presented at EASL earlier this year. So that's one path, I would say, of additional analysis. And the other main path is a number of analysis on the variety of markers of cardiometabolic health. NASH, as we all know, is a metabolic immune liver disease, and pan-PPAR agonists, as lanifibranor, acts on the three isoforms of PPAR transcription factors, alpha, beta, delta, and gamma. Now, these have distinct overlapping roles in the regulation of metabolism, lipid metabolism, insulin resistance, inflammation in the liver and in adipose tissue, and in many other organs and tissues that are involved in metabolism homeostasis. So you expect that lanifibranor has a beneficial effect on these markers as well. They are upstream in the NASH disease biology, and at the same time they represent risk factors for cardiometabolic health. And in the analysis we have covered the effect of lanifibranor compared to placebo on lipid metabolism, on control of glycemia, insulin resistance, systemic inflammation, diastolic blood pressure, and also hepatic steatosis measured by ultrasound-based imaging, a FibroScan-AST. And those data confirm indeed that lanifibranor has that broad effect on the NASH disease biology. Now, some noteworthy information, about 1/3 of the patient, or additional information, about 1/3 of the patients who have lanifibranor have an increase of weight, if you define it as 5% increase over baseline or more. And we've shown that these patients have actually the same degree of improvement of their cardiometabolic health. So their insulin sensitivity improves, their hepatic fat decreases, and so on, which has been described also for other PPAR agonists, that the weight change is completely independent of the change, or the metabolic improvement is completely independent of the change in weight. So that's, I think, a noteworthy aspect. And another one which I think is worth mentioning is that 40% of patients have type 2 diabetes, but among those who do not have type 2 diabetes, substantial proportion have pre-diabetes, defined by a high fasting glucose level. And those patients, also the majority of them, after lanifibranor treatment, have normal fasting glucose levels, so that the pre-diabetic status is returned to normal in those patients. So that has been our focus of our presentations in the past year.
There's a lot of positive momentum with lanifibranor in this field, in the treatment of NASH, and where this mechanism actually is headed. A lot of positive traction. And so maybe before we talk about the phase 3 trial, drilling down on the phase 2, just to provide a little more color for the audience, I wanted to ask a little bit about two things. One, the methodology that you used in interpreting the histopathology, because it is in some ways a bit different than others and in some ways similar, but I think it's worthy of a discussion just briefly. And then the second point is drilling down a bit more on some of the extrahepatic benefits of the drug. One of the things I like about lanifibranor is that it does target multiple different pathways. And in doing that, it has the benefit of actually helping not only the liver disease, as measured histopathologically, but some of the metabolic components as well. And I think it's maybe worthy of a bit more discussion there. So first question, Michael, would be diving into the biopsy methodology a bit more. It's a bit all over the map how companies read out histology. And so maybe if you could take a moment just to talk through how you read out the phase 2B, looking at the SAF versus the NASH CRN, and how your liver biopsies were read. Was it one pathologist, two? Was it consensus read? Just a little bit of color there if you don't mind.
You're right that we use two different scores. In native, we use the SAF score and the NASH CRN score. The rationale for choosing the SAF score was essentially to make sure that patients who are enrolled in the native study have a certain degree of inflammation and a certain degree of tissue injury measured with ballooning degeneration, so that you target the patient population that is assumed to need it most. The primary efficacy endpoint in the native study was also based on the SAF score. Now, if you look at, the NASH CRN score was used as a second secondary efficacy endpoint. But it's, I think, important to mention that the efficacy, so defined as the difference between the two doses and placebo, were actually quite comparable whether or not you apply the SAF score or the NASH CRN score. And also, if you define NASH improvement including steatosis, which you don't do in the primary efficacy endpoint, but when you do that, you actually come to the same efficacy results, because lanifibranor also leads to a reduction of hepatic fat, as we have shown previously. With regard to, or in the NATIVE study, the biopsy samples at the end of the study were read serially by one pathologist, Pierre Bedoza, who at the time of the reading was not aware when the samples were obtained, so baseline or end of the assigned regimen. And we of course realized that the variability between observers and also within one observer has been a big challenge with regard to the scoring of liver biopsies. And in order to adjust that or control that as good as is possible, I believe, for NATIVE 3, we have a team of 3 expert pathologists who will read each biopsy in a way that eligibility and also at the end of the treatment, the scoring is based on a consensus between 2 of the 3 pathologists. And if there is no consensus on one of the critical evaluations for eligibility, then there is a 3rd pathologist who is a tiebreaker. So that's how we address as much as we can the variability that is inherent, I think, to the scoring system that we apply in using histology readouts.
I totally agree. I mean, I think we struggle with the variability, the sampling variability, the heterogeneity of the biopsy tissue, and then, of course, the inter-observer variability. So I think the field has certainly moved towards trying to achieve some sort of consensus, and whether it's 2 pathologists or 3, I think gaining consensus of at least 2 of the 3 is kind of where the field has migrated to. It would be interesting to see how AI digital pathology figures out how to integrate into that, and do they integrate into that in some sort of hybrid assessment at the end of the day. And I think we'd need a little bit more data, but there is some signal that potentially including AI digital pathology may stabilize placebo response rates a bit. I think that data has been presented numerous times, not published fully yet in manuscript form, but something to keep an eye on. Michael, just drilling down a little bit more on the extrahepatic benefits and reflecting back on the New England Journal paper, there were some broad comments made relative to the improvement in glycemic control, which you would expect with this type of mechanism, and also on some of the lipid parameters, particularly improvement in HDL cholesterol and a lowering in triglyceride levels. Any additional follow-up comments from you in there, or additional analyses that were done in that regard?
Yeah, of course, we had to do the analysis based on the samples that were available and the analysis done at the time that NATIVE was conducted. So with regard to lipid profiles, we have shown that total triglycerides go down significantly with lanifibranor, that HDL cholesterol goes up with lanifibranor compared to placebo. And we have also looked at the apolipoproteins A1, B, and C3 and the ratio of A1 and B, and that also improves in the right direction, clearly, with lanifibranor. And these changes are seen equally in patients who have diabetes and who don't have diabetes. As I mentioned before, they're also seen equally in patients who have a stable weight, which is about half of the patients, and the 1/3 who have an increase in weight of more than 5% or 5% or more. So we have a clear effect on insulin resistance. I think that's a relevant finding, and also on systemic inflammation, HS-CRP, which is also a well-known risk factor for cardiovascular disease. So everything that was looked at really improves in the right direction. If you look at...
I was really impressed with the highly sensitive CRP reduction. And that often doesn't get talked about as much in the hepatology field, maybe as much as it does in the cardiometabolic field. So I think it is important to highlight what you've shown with Lani in the phase 2, and looking forward to see, how that translates into phase 3 as well.
Yes, that's an interesting, it's interesting that you mentioned that, Stephen, because indeed I have had the opportunity to discuss our data with cardiologists, and they usually are very impressed by the effect on HS-CRP.
Why don't we move on in our discussion discussion. And if you could take a few minutes and tell us, first of all, what will you be sharing this week at the liver meeting?
Thank you. So the presentation at AASLD later this week is all about adiponectin and adiponectin levels in the NATIVE study. So adiponectin is an adipokine that is related to insulin sensitivity, metabolic health of adipose tissue, maturation of adipose tissue. So it's quite an important messaging molecule in metabolism, and it's downstream of PPAR signaling. It's been shown that patients with NASH and also with cardiovascular disease have low levels of adiponectin on average, and we see that indeed in the patients who were enrolled in NATIVE. And in both lanifibranor arms, adiponectin increases, and that increase correlates nicely with the improvement of the several markers of cardiometabolic health that we've just discussed. So you do not see that in placebo. There's no increase in adiponectin, and the markers of cardiometabolic health also don't improve or get worse even. So it basically links the improvement of cardiometabolic health, at least to an important part, to adiponectin and the mechanism of action of lanifibranor, and that will be presented on Saturday, or this Saturday.
Okay, thank you. So Michael, can you tell us a little bit about your phase 3 trial for Lani?
Yeah, sure. So phase 3 study is the NATIVE-3 study. It's our pivotal study to confirm the therapeutic benefit of lanifibranor in patients with NASH and fibrosis, not cirrhosis. The goal is, of course, to obtain approval for these patients. The inclusion criteria are kept as close as possible to those of NATIVE. Of course, the treatment duration is longer, but we have similar criteria for the activity of the disease, so NASH inflammation and ballooning degeneration. And with regard to fibrosis, patients need to have stages F2 and F3. So that's the patient population that by and large needs treatment most. The study has two parts. The first part is enrolling up to 900 patients, and there will be a biopsy after 72 weeks of treatment. And that biopsy, compared to baseline, will then be used to evaluate, confirm the primary efficacy endpoint for this analysis, which is, again, the NASH resolution and improvement of fibrosis. And we have chosen this high bar endpoint based on our NATIVE results, and confident that lanifibranor has this effect on NASH. We have a number of secondary efficacy endpoints, both histological, but also a lot of non-invasive endpoints, so that we get a holistic view of what lanifibranor does in patients with NASH. And we aim to submit the data for accelerated approval based on histology according to subpart H with the FDA. And then treatment will continue for a longer period. It's 5 to 7 years, depending on when the patient enters the study. And we will enroll additional patients to have a larger database. And that part 2 is meant to show outcome benefit. Outcome benefit is mostly progression to cirrhosis or complications of cirrhosis, all-cause mortality. And the data from that part, the outcome benefit, will lead to a full approval of lanifibranor. So that's the overall plan. We have kept 2 doses in the phase 3 study, and the reasons for that are that if you look at the fibrosis scoring, the higher dose, 1200 milligram, does better than 800 milligram, although both are better than placebo. If you look at the metabolic markers, the markers of cardiometabolic health, both doses are actually having the same effect on all these markers. So we reason that it's quite possible that if you treat longer, like a year and a half in this case, that both doses will be equally efficacious on the histological readout. That remains to be seen, but that's the reason why we have kept the 2 doses.
I think it's important, a couple really key points to highlight from your comments. Number one, the robust endpoint of both NASH resolution and fibrosis improvement, which is a very stringent endpoint, and one that if it's hit, that's what the EMA is looking for sure, and the FDA would be fine with that. So kudos to you for picking a stringent endpoint and having the confidence based on the phase 2 to design it that way. And then also that you're carrying forward both doses, the 800 and 1200 milligram. And just also for the listeners again, could you comment on the duration of the phase 3 trial for the surrogate endpoint of histology that you mentioned? For one, I just want to make sure that's clear. And also, number 2, as you reflect on some of where the field is headed now, I'd like to get your thoughts relative to where you're headed with cirrhosis. And do you see that lanifibranor could have a benefit in preventing progression of disease in a cirrhotic population? And if so, are there any plans to potentially study that population? And if you chose chose to do that, would you consider something like what Madrigal is doing, where they're doing a phase 3 in well-compensated cirrhotics that would provide a potential benefit back to your registration trial?
Yeah, thank you. Those are very good questions indeed. I think with regard to the duration of part 1 in the current phase 3 study, I think that was your first question. The duration is 72 weeks, and the native has a treatment duration of 6 months and has already shown quite an improvement, a meaningful improvement of fibrosis if you score it according to the staging. So you could argue that a year may be enough. On the other hand, a year and a half also gives us a more robust safety database. What happens if you treat longer? And that's an important aspect with regard to how the FDA sees the data that they would like to see. And that's an important component of the reasons why we took 72 weeks of treatment. The other question was with regard to cirrhosis. So yes, I mean, there has been a lot of discussion also going back to the communications from the FDA about an alternative pathway to obtain approval for NASH by doing adding a study in patients with compensated cirrhosis using outcome benefit here defined as reduction of the occurrence of decompensation of cirrhosis as a perspective of the treatment benefit. And I think lanifibranor certainly has the same potential in this patient population when you talk about patients with compensated cirrhosis. Because it being a pan-PPAR agonist, it does have an effect on metabolism, it does have an effect on inflammation as well as on fibrosis, and also actually on the endothelial cell functioning, something that we didn't speak about, but there are also data on the protective role, to summarize it that way, of PPAR signaling on the functioning of endothelial cells, which will also be important in the progression of cirrhosis. So if you take that together, I think that the progression of fibrosis and cirrhosis is driven by metabolism, by inflammation, as well as the fibrosis progress, that lanifibranor, based on its mechanism of action, has all the potential to actually be efficacious in patients with compensated cirrhosis as well. And we certainly think a lot about that, and we do consider those plans. That's right.
So, Michael, we've had some discussion already on the podcast on Legend, your combination trial, and would love your feedback on that trial and its design and what it tells us about your view of the future of Lani in combination therapy.
Yeah, thank you. So Legend is a proof of concept study, and we want to evaluate the effect of the combination of lanifibranor with empagliflozin in patients with NASH and type 2 diabetes, and using a biologically meaningful endpoint, which is the idea of a proof of concept study. It's a treatment duration of 6 months. HbA1c is the primary efficacy endpoint, which is, of course, an endpoint in type 2 diabetes studies, but also is pathogenetically upstream in the disease biology of NASH, which does tell us about what you would expect for patients with NAFLD NASH as well. And then there are a large number of secondary efficacy endpoints, which will provide valuable information about improvement of metabolism, the distribution of adipose tissue, for example, which is important by using blood markers, but also ultrasound and MRI-based imaging. So what is our thinking about combination treatment? I think that lanifibranor in itself addresses the broad biology of NASH. Many patients with NASH will be fine, I think, with lanifibranor treatment, but there will be patients who will benefit from an additional medicine, from a combination treatment. So I would compare that very much with the situation of how we treat type 2 diabetes. It's the response of individual patients that will inform doctors who will benefit from a combination treatment and when a treatment can be added. So the combination of lanifibranor with empagliflozin is expected to have an additional benefit on the metabolic improvement upstream in the disease biology, which will reflect downstream of the disease at later points in time. And there is quite some data from several SGLT2 inhibitors and pioglitazone that that's indeed the case. So you have a further improvement compared to pioglitazone alone on HbA1c and so on. And in addition, for some patients, the weight increase may be a concern. So we know that if you combine an SGLT2 inhibitor with lanifibranor, balances out the weight changes. So that's an additional aspect that is, I think, relevant to look at.
I think this is terrific. You had mentioned briefly this trial is 6 months in duration and it's focused on HbA1c, but you're also doing some non-invasive assessment of liver health, right? So can you comment on what those non-invasive tests are?
Yeah, sure. I mean, it's the usual, what we discussed earlier, the markers of cardiometabolic metabolic health, liver injury, and inflammation. We do not use biopsy for follow-up in these patients, but we do apply ultrasound-based imaging, so FibroScan-CAP, and also multi-scan MRI. So we'll look at multi-parametric MRI to evaluate not just the liver, but also the hepatic fat, the adipose tissue distribution in the body as well. So those are the non-invasive tests.
I think those are terrific. I particularly like the idea of multi-parametric MRI here, looking at corrected T1 to see not only liver fat content reduction, but also an effect on disease activity. What's happening to inflammation in these patients. That's exciting.
So, Michael, I certainly agree with Stephen. I think that the design of the trial is exciting in that it promises a broader view of disease than simply sticking within the conventional NASH window.
I think this has been incredibly helpful, Michael. I think just being able to unpack this compound, to be able to dive into your brain a bit and talk about your plans for lanifibranor and how it fits into the armamentarium of what we have to offer our NASH patients has been incredibly insightful and helpful, and look forward to seeing you here in a couple days.
Michael, I completely agree with everything Stephen said. We probably get as many questions about Lani that I cannot answer as any other compound that people from outside the podcast ask about. This has been an amazingly helpful opportunity to clear some of that up. Stephen, thanks for making the time today. I know this is a crazy week for you. Michael, thank you so much for joining us, and I look forward to seeing both of you gents later in the week.
Sounds good.
Thank you, Roger. Thank you, Stephen. See you in Washington.
Thank you. Okay, bye-bye.
This episode of Surfing the NASH Tsunami has been sponsored by Inventiva, a leading French biotech company developing novel and differentiated oral small molecule therapies for patients with NASH and other diseases with significant unmet medical needs. For more information about Inventiva and its NASH therapies, visit inventivapharma.com.
Next Monday, join Jörn, Roger, and their guests to review high points of a stimulating liver meeting 2022. Until then, as Roger likes to say, stay safe, surf on, and we'll see you on the podcast next week, here on Surfing the NASH Tsunami.